¿Quieres que traiga agua o algo?
No, he bebido mucho.
Hello. So it's all set. So so I guess I have to start over the introduction, I guess. So it's my pleasure to introduce our last speaker of the series of seminar, who is Laura Cerviño. Laura also took her degree in aerospace engineering in the Polytechnic University of Madrid. Then he did the PhD in San Diego also. Incidentally, although the topic that she's going to talk about goes more in the range of medical imaging and all that, she did a PhD in direct numerical simulations, also coming from the world of fluid mechanics. And then after doing the PhD, she was a visiting professor in Sevilla for a while, I guess one academic year or something like that. And then he moved back to San Diego, to UC San Diego, where she was a postdoc for some time. And then now she's a researcher at the Cancer Center in the hospital of the university. So Laura, thank you very much for your presence here today. So we are all set to listen to your wonderful presentation.
Okay, thank you. Can you hear me?
Perfectly.
Yeah. So thank you, Javi, for the opportunity to give this talk. It would be much better to be there, but maybe next time. So let me open my presentation. So today I'm going to talk about a project which is in progress on deformable image registration for dose accumulation in gynecological brachytherapy. And as a disclaimer, there are no fluid dynamics equations in this talk. And I know that's shocking sometimes, but we have to live with it. So first I'll give an introduction about basically radiation therapy, since I know most people are not familiar with that. And then cervical cancer, radiotherapy for cervical cancer, why we want to do dose accumulation and the challenges that we face, and a little bit about deformable image registration. And then I talk about the method that we are working on to overcome these challenges, specifically in brachytherapy, and show some preliminary results that we have and talk about the conclusions and the future work. So radiotherapy for cancer treatment. Radiotherapy is the medical use of ionizing radiation. For cancer treatment, specifically, it uses high-energy radiation to kill cancers, and the way it does it is damaging the DNA of the cells. Now, it kills both normal cells and cancer cells. So we work hard to optimize our treatment plans in order to minimize radiation to healthy tissues and just irradiating the cancer cells. Now, radiotherapy can be used before, during, or after surgery, depending on the type of the cancer and the stage of the cancer, and it may be used alone or in combination with chemotherapy as well. And about half of all cancer patients receive some type of radiation therapy sometime during the course of their treatment. So it's very used in cancer. There are two main types of radiotherapy. One is external beam radiation therapy, which is on your left. And basically, this is just photons or particles coming from an accelerator. So the most common use is a linear accelerator. So there is a linear accelerator where I'm pointing now with my mouse, or with a pointer.
With my mouse.
With my mouse. Juan Carlos' mouse. And the radiation comes to the patient from top to bottom. Now, this linear accelerator, or LINAC as we call it, it can rotate around the patient, so it can provide radiation, it can deliver radiation from different angles around the patient. And that's the way we have, or one of the ways we have, to minimize radiation to healthy tissues and just try to make our therapy very conformal to our target or tumor. Another type of radiotherapy is brachytherapy. And this comes from radioactive sources, usually. The difference is we, rather than giving the radiation from outside, like we do with external beam radiotherapy, we deliver radiotherapy from inside of the patient. So here you see. There are many ways to do this, and this is the way we do it for cervical cancer, which is the subject of this talk. And here you have an applicator, so this is a tandem, it's called tandem. It goes inserted into, so you insert it through the vagina, through the cervix, and then into the uterus. And you might have here ovoids also, or this is a ring, although you have to see it in perspective. And they are connected to different channels. And you see here 2 channels. Now this connects to a machine that is an afterloader that has a tiny radioactive source. And this tiny radioactive source comes through the channels, to each channel one at a time, and stops at different positions in these channels, and delivering radiation. And your treatment plan, in this case, consists on how much time and where does this radioactive seed need to stop. Okay, so cervical cancer, this comes from the NCI webpage, the National Cancer Institute. There are in this year in the United States, there are an estimated 12,000 new cases. And there are an estimated 4,000 deaths in 2013. The 5-year survival rate is at 67%, so that means that about 67 in 100 patients who are diagnosed today will live in 5 years. And of course, this is not homogeneous. It heavily depends on the stage at diagnosis. So if it's very localized, the 5-year survival rate is very high. If as your stage increases, so it's more either metastasized or it has invaded some other tissues, your 5-year survival rate decreases. And in this plot here, you can see that with time, the number of new cases diagnosed every year has been getting lower and lower. And one explanation is that people stop using hormone replacement therapy postmenopausal. And also the number of deaths has been decreasing consistently with the number of new cases. However, if you look at this, the 5-year relative survival has kept basically the same. So radiotherapy for cervical cancer, it is well known that in general, cervical cancer responds rapidly to radiotherapy. So radiotherapy is a big component on the treatment of cervical cancer. And usually it consists of a combination of the 2 techniques that we talked about, external beam radiotherapy from outside of the body. And these can be and this is just an example, there are different regimes, but one example is they give you 1.8 grays per treatment, and you have to go to 25 treatments. Now, gray is the unit that we use for dose, absorbed dose in the body. And that's the unit that we use in radiation, and it's joules per kilogram, basically. And then that is combined with brachytherapy, which is from inside, and it gives you a higher dose per treatment than external beam radiotherapy. So you might need to come for 5 treatments, and each treatment they give you 6 gray. And again, this is an example. One of the problems with cervical cancer and radiotherapy is that radiotherapy has lagged behind. What do I mean with this? Is as the technology to treat cancer and to provide radiotherapy has advanced, still many people give the same treatment to cervical cancer patients that they were giving 15 years ago, for example. This was a survey in 2003 and about the use of intensively modulated radiation therapy. And you can see, and this was a new technique at the time, but it was heavily used in some cancer sites, but gynecology was lagging behind. And moreover, the brachytherapy for cervical cancer has really lagged behind. And what I mean with in this case is, okay, here you have the anatomy of, you have the vagina, you have the cervix of the patient, and you have the uterus. And the way we deliver radiation is we usually put this tandem that I showed before, and this is a radiograph where you can see a real one. So this is a tandem. And then on the sides, you can have the two ovoids, here and here. So it's these two ovoids on the radiograph, or a ring, like I said before. Anyway, so we deliver radiation in all the ovoids and the tandem. But the way we deliver it, or many people deliver it, is you use a prescription point. So you do a standard loading, meaning that you use a standard plan. So you load all the tandem from the tip to here, more or less, and then you load some a little bit on the ovoids, and the radiation that you give in each of them is very standard. So you do everything proportional. So 1/3 of the tip, basically, you give 10 or 15. Sorry, if you give 15 seconds in the tip, then you give 10 on the other 2/3, and then 15 on the ovoids and 15 on the ovoids. Very standard. Everyone does it that way. Then you obtain a dose, and these are isodose lines. As you can see here, it has a pear shape. And you normalize this dose to a point that is 2 centimeters from the cervical os, which is the entrance or the end of the vagina, basically, and 2 centimeters to the side. So if you want to give 6th grade to this patient, you are normalizing the dose here to obtain 6th grade at this point, and it's called point A. Now, this is very standard, 2 centimeters to the top, 2 centimeters to the side, no matter whether your uterus is really big, your uterus is really small. So everyone gets the same treatment. And nowadays, with all the imaging that we can do, this doesn't make any sense anymore. I mean, before they didn't have all this information, but now this is supposed to be, this point is supposed to be in some vessels of the uterus, but again, in some patients it might be outside of the uterus. So now there is much interest on trying to improve and benefit from image guidance in all these treatments, both external and brachytherapy. And there are clinical trials. This is just an example of one clinical trial, how the design is. So it's a phase 2-3 clinical trial. It has different arms. So those are the different options that you have in a clinical trial. One is using IMRT, so intensively modulated radiotherapy. Another one is using the conventional radiotherapy. So still, now we have a clinical trial that is comparing two techniques that were developed a long time ago. So gynecological cancer is really lagging behind in these cases. And then brachytherapy is used in all arms. And there is no specification on how the brachytherapy is done. And let me go back to this slide. Brachytherapy. Now many physicians are taking advantage of image guidance, and rather than using this 8-point, if they see the rectum closed, you don't want to irradiate the rectum because then you will have fistulas, and you don't want to irradiate the bladder too much either. So healthy organs, you don't want to irradiate them. But there are many people who are really hesitant to move away from this way of treating. So the ultimate goal of all this research, and again, this is ultimate, far away from today, is to adapt the treatment to the daily anatomy and to what the patient has previously received. So you can use adaptive external beam radiotherapy, and you can do replanning based on deformed images. So I have a treatment plan that I use for the patient. Now the patient comes for treatment, and suddenly I realize with the images that the anatomy has changed. So I need to deform one image to the next one and see how can I adapt my plan, and how can I deform the doses, and how can I add up those doses. If the anatomy is different, how can I sum those doses to take that into account for the third fraction, for example? And you need to use deformable registration. And in the same way, you want to do that also with brachytherapy. So if one day you achieve something or some dose distribution in the patient, the next day you might want to adapt your plan to give a little bit more or a little bit less based on what you gave last time. So the challenges in dose assessment or dose accumulation is basically for cervical cancer you want to add both the external beam radiotherapy and the brachytherapy. But the anatomy in both of them is completely different. And you have here on the left, you have an axial slice, what is called coronal and sagittal slice of a CAT CT scan, finished TAC, the CT scan, of the patient without any brachytherapy applicator. So this is the scan that is used for planning external beam radiotherapy. And now on the right, you have the CT scan of the patient with a brachytherapy application that you use for brachytherapy planning. So the problem is, how do you deform this image to this one? And it's really complicated, and deformable registration nowadays is not even extremely accurate if the anatomy is similar, so much less with different anatomies. And the methods that are usually currently used are based on image intensity. So it's going to try to match this image based on intensities to this image based on intensities, but there is no, you see there is this bright applicator here that is not here. So who knows what this algorithm is going to do to need to match this image to this other image. And the same for different brachytherapy fractions. The anatomy is never the same. The ovoids, for example, have different sizes, and the physician might use different sizes, different days. The tandem might be slightly different days too. So you need to be careful when you do the deformation. And another challenge that I mentioned, but we don't even tackle that here, is you cannot directly add doses like 5 + 5 = 10, because the biological effect of the two different radiation is very different. So there are also radiobiologists working on that field. So this is just a schematic of what Demon's deformable registration does. And this is a phantom that we created of an axial slice of a head. So this is the mandible, basically. This is the carotid spine, and there is a tumor here. Now, we can, and the tumor we did it with an inflatable balloon, so we can put water in the balloon, and then we took a CT scan of this phantom. Now we simulate tumor shrinkage of this tumor by removing some of that water, and then you can see that it's like if the tumor were smaller. So what the deformable registration does is it tries to match both images, and it gives you a deformation vector field that you need to apply to this image in order to get this other image. So that is, in 2 words, deformable registration. And again, we use demons. I mean, there are many other ways. For example, finite elements would be another way of doing deformable registration, but it's much more complicated and You would need to simulate everything you have inside, give properties to every different tissue, so it's not obvious how to do that. So people just go ahead and use image intensity. One challenge is this is a homogeneous intensity area, and this one is 2. So because it's homogeneous, there is no change in intensity. Your Demon's deformable registration algorithm is going to give you some vectors there, but they might not be accurate because it's not detecting any change in intensity. But still, it's the best tool we have right now, and the tumors or tissue is not as homogeneous as water, luckily. So the proposed work is to try to find a method to perform deformable registration of CT scans with brachytherapy applicators. The workflow goes like this. We first find the applicator, we then remove the applicator. The idea is to deflate this applicator in order to register these images to external beam radiotherapy. And I'm just going to briefly mention this afterwards because we haven't gotten there yet, but I'll mention it at the end. And then we apply deformable registration and we deform and accumulate doses. And let me tell you that this is really a challenge even in clinical trials. So the people who do brachytherapy and research in brachytherapy, and then they do different clinical trials, and then they want to study outcomes and toxicities. They get a lot of criticism because they cannot add doses linearly, and that's the way they are doing it now, but they can't. So they get a lot of criticism, and no one has come up with a good way to deform these images and accumulate those. So again, this is the brachy to brachy dose accumulation. First, we do the segmentation, which is finding our applicator. Then we do the deflation. In fact, we only do the deflation if we want to accumulate those with external beam radiotherapy. And then we use deformable image registration, which has been studied before. So for the segmentation, we have implemented a random walks algorithm in GPU, so it's fast. It's semi-automatic. You need to mark some seed points manually, and then everything else is automatically. And it requires a library for sparse linear algebra, and it's written in CUDA for the GPU, and it takes about 30 seconds. This is for 3D images. So I'll skip this. This is just basically how random walks segmentation is done, but basically you put a seed point, and it's trying to find all the points that it finds close to you that belong to that same tissue type, and it's solving a direct problem. So I show some of the segmentation results for different organs. So for example here, we are manually putting these seeds on one plane. So we just mark seeds, which means our seeding points for the random walks algorithms. So you say, okay, this is foreground, which is, this is what I want to get. Your applicator, or here is your bone marrow. And this is your background. So this is not what I want. And in this case, we can see here, after the 3D segmentation and random walks, that it found quite well your bone marrow. And again, it's based on intensity. So if any intensity is similar to what you put on your seeds, it's going to mark that. Now, in this case, we use it to find the whole body. So we put our seeds here and say, okay, this is what we want. And again, we just put it on one axial slice of your CT scan, so it's only going to be in one image here. and then it will propagate that into superiorly of the patient and inferiorly of the patient, and it does a good job of finding the body. Now the problem is we want to find our applicator, and here you can see the tandems here, and this is the the tandem is here, and you have the ovoids on the side. So you put your seed points on just one plane, and then this is which is your foreground, we call it, and then this is the background around, and you try to apply it, and this is your result. So it does a very poor job trying to find your applicator. And again, this is just from one slice to the 3D. So we clearly see that it's not working. And the problem is, and here you have 3 different applicators. This is a cylinder, this is a tandem and a cylinder, and this is a tandem here, and you have fluid or gel or gauze inside the vagina just to pack it so it doesn't move inside the vagina. And the problem is you are trying to detect something that has a wide range of intensities. So that's why your algorithm is not working so well. Again, here the same, you are trying to find something that has a wide range of intensities. So that's why it's not working. So the solution is, okay, now we'll see one actual slide, but we need to grow that to the other slices because you don't want to manually mark all your slices. And the way that was solved is by trying to study probabilities of voxels to belong to the foreground or to the background. So in your image you can basically estimate or model the probability that that voxel is foreground or background, and then you can calculate the probability that you have of including one point into your foreground, and that because we're interested only on the foreground, on the applicator. And if that probability is higher than 90%, then we add it to our foreground pool. So this is the result of the automatic seeding extension, and we mark one slice, and then it propagates this to different slices, and you can see that it's not the whole applicator, but that's okay because these are just our seeding points for the random walks algorithm. So here we only had one line of seeds, now we have many more, but that's okay. So it basically puts seeds in all the planes automatically, so we don't have to do that manually. And now if you apply your random walk segmentation, and now you need to mark your background too, we can see that it does a much better job finding the applicator. And it's not only the applicator, it's also the surrounding, anything that is in the vagina or in the uterus, and that is not tissue, basically. It's not the patient, anything external. So we evaluated the segmentation results with 3 patients and total of 9 fractions, and we compared the automatic segmentation with manual segmentation performed by a radiation oncologist. And a way to quantify the performance is to use the dice coefficient, which is basically how the intersection of both segmentations is compared with the sum of both segmentation. So this is just one case. You see the dice coefficients are quite good in general. They're always about 0.9, so it's not bad, but it is not perfect. And you can see here is the segmentation. So whatever is inside this salmon color contour is what it feels that it's the applicator. So this is very good because, again, this is the tandem plus some gauze that is inserted in the patient for packing so it doesn't move. It fails sometimes in some parts of the patient but it is quite good in general. Here again, it's picking up the everything, the gauze, the tandem, the ovoids, and here it just fades slightly because it's removing, or it's taking part of the patient too. In this case, it would be okay because we deliver those here and not here, so that wouldn't be so bad. And here again, so I'm just showing different cases. So we were very excited with this, and again, this is an in progress project, but like I said, no one has come up with an idea to deal with the applicators. And here again, it's picking up the applicator and inside very well. This is a tandem and cylinder, so this is a cylinder inserted in the vagina with a tandem going into the uterus. And so, once we did this, some people suggested, okay, do you really need to remove the applicator? I mean, we were quite convinced that yes, you do. Because the placement of the applicator in every fraction is not reproducible, and there is relative motion from the applicator and your healthy tissues every day. So one day it might be here, the other day it might be slightly down, but this algorithm gives you a continuous deformation, so there is no slippage in this algorithm, it's continuous. So we simulated, we just grabbed segmented our applicator, so this is a cylinder, we moved it slightly, and then we did the deformation of the images, and you see that the deformation or the motion of the cylinder downward here gets propagated into your tissue, and that's something you want to avoid, and you avoid if you just get rid of the applicator. And this is a plot that is showing, basically we have the first row is just one treatment day, the second row is a different treatment day, and the third row is the deformation from the second one to the first one, if you have the applicator and if you don't have the applicator. And then here on the bottom of the right, you can see the difference between both deformations. So this deformation, the difference is this one. And we can see that the biggest differences happen where you have, around where you have the applicator. And here we just quantify a little bit. And it can be, the differences could be, in this case, up to 2 centimeters. And 2 centimeters, just to explain you brachytherapy, we do everything to the millimeter, and in general we do everything to the millimeter. So being 2 centimeters off in your treatment means that you are way off. And this is just a preliminary result on those accumulation from excuse me, from two fractions. So again, on the first column we have the first fraction, so we have a tandem and ovoids. We remove the applicator, and this is the dose that we get, and you see that the dose, of course, you have removed all the central part, is completely different to the dose that you have here. And you might think, okay, you are missing a big piece of information. But the thing is, you are only missing the dose that you are giving to the tandem, which you don't, or to the applicator, which is not dose to the patient, so you don't need that at all. But you just want to keep the dose that you are giving to the patient. Here is a second treatment day. And this is, for example, a longer treatment. This is a tandem cylinder. So you give radiation also in the vagina, and then again you remove the applicator. And you can see that just to give some radiation on the sides of the applicator, you have to give a very high dose at the center. But again, you don't care about that because that's dose to a device, not to a patient. Here is finally the dose accumulation. When this is the dose accumulation if you don't remove the applicators. This is, you see the deformable registration, it really does a crappy job trying to deform this. And if we remove the applicator, you get something that is looks like your first fraction, basically, because that's what you're doing, and you can add doses. Again, this is very hard to validate for many reasons. You never have a ground truth of your deformations, your patients, but I mean, we are working on trying to validate this. Still, this is not perfect, and we have some deformation errors, especially, I think this is upside down, at the tip of the tandem. We think it's because if there is relative motion of the tandem, there is a big deformation at that point, at the tip. So it's not being so good there. So we are working on improving that using a non-rigid robust point matching method that would be used as initialization to Demon's algorithm. And here is just a preliminary test that we did. So green and pink are the two applicators from one day. This is just applying regular Demons, the second row, and you can see the error at the tip of the tandem. And if we apply the RPM method, we obtain a much better result. So in conclusion, we are developing basically a novel and robust deformable image registration scheme that can perform registration between HDR or brachytherapy gynecological CT images. The process consists of segmentation, applicator removal, and deformable registration and dose accumulation. And the initial results that we have are quite promising. We are currently working on improving the deformation at the tip of the tandem. And once we are happy with our brachy to brachy image registration, we'll jump into deforming external beam images to brachytherapy images, but there are many challenges there too, so we just started with the easy part. One of the challenges that appear is here. You have your brachytherapy image, and you have removed the applicator, and now you want to match this to an image from external beam radiotherapy that doesn't have an applicator but doesn't have this hole either, or this cavity, right? So you need to get rid of this cavity, and one way to do it is to deflate. Assume this is a balloon, for example, and virtually deflate it to a small cavity so it doesn't collapse to a point, and then fill in this small cavity. But if you look at here, so this one looks quite okay, but if you look at this other image, this is your bladder. When you do the deflation, or everything collapses, then your bladder becomes with a very weird shape. And deforming this to an external beam radiotherapy is not going to give you very good results. So that's challenging, but that's what we are working on. And last, I want to acknowledge all my collaborators on this. Most of us were together at UC San Diego at some point, or a couple of years ago, but many people left. The main contributor to this project is Xin Zhen. He was a postdoc here, and now he's a professor in China. some physicians at UC San Diego, Dr. Yashar and Dr. Mel, some researchers that moved to Southwestern, Professor Jia, Professor Gu, Hao Yang, and Professor Zhang. And that's all. Thank you so much for the opportunity again. That's it.
Okay, thank you so much. So it's an open turn for questions. Does anybody have a question? Yeah, I do have a question myself. I don't know if I got it right, but the main reason why the dose is not additive, is it because the tissue moves from day to day when you do the treatment, or is because if you were able to locate exactly the same parcel of tissue, still the dose wouldn't be additive or accumulative? So what is like the ultimate reason for the dose not being additive?
Both. First, you need to find a way to say, okay, this point today was this point yesterday, right? So the anatomy slightly or greatly changes, and if you give 2 gray here today and 3 gray here yesterday, you need to, to find that point-to-point correspondence in the images. And the second thing is the biological effect or radiobiological effect of its different types of radiation is slightly different, or greatly different too. And the problem is that's not well studied, and there are many people, it's not well studied. There are some theories, but nothing in radiobiology is for sure now. I hope this project, for example, if you can add doses, eventually you could, if you can add doses anatomically correctly, then you can study if you are adding those doses biologically correctly.
Okay, thank you very much. So it's a very interesting and open question to do the research, so to see what happened in there and why the dose is not additive. So I think I will keep thinking about that for a long time. So any more questions? Okay, so thank you very much. You have a question, Juan Carlos? Okay.
Yes.
Yeah. So
you mentioned that when you're trying to remove the applicator, and all the gel and all that stuff that is there, would it be possible to maybe use some sort of contrast agent in that gel? I don't know if there are side effects to that, or that would maybe make more, but it would make the whole region glow. It might be it might be easier because you wouldn't have such an effect already new.
Yeah, it's possible. But the thing is, it's not only that. You have the ovoids, which are one material. You have the tandem, which is it's a metal. In fact, the ovoids are kind of plastic or, And then you have not only gel, it's gauze that you have, but yeah, you can add contrast. And somehow, you could, for example, we are doing now for prostate treatments, we need to add contrast to find the urethra, and we just inject something with microbubbles. We just create the microbubbles, basically. And that will give you enough contrast in ultrasound, so it depends.
Yeah.
It's possible to add contrast, yes. But it's not going to be so accurate anyways, because it's not going to go all the way in.
And the second question I had is, have you thought of maybe doing multimodality imaging to increase the accuracy somehow?
So, yes, the problem with this is you need to image every day for treatment, right? For brachytherapy. You bring the patient, you insert the applicator, then you do a CT scan of the patient. And some people are doing MRI, which is great. But you need to have your MRI. That's the problem.
Okay.
Yes.
More questions here in the audience or there in San Diego? Okay, so let's thank this time both speakers from abroad, from San Diego.
Ahora vais a cenar y nosotros a tomarnos un café, ¿no?
Gracias.
Sí, yo creo que realmente ya no queda ningún English speaker. Muchas gracias a los dos por participar desde allí, que sé que os habéis tenido que dar el madrugón, etcétera, etcétera. O sea que nada. Bueno, pues de todas formas, muchísimas gracias por vuestras charlas y que, bueno, esperamos veros por aquí pronto y la próxima edición, me imagino que repetiremos el año que viene, que podéis estar aquí físicamente y
Sí, Javi, yo te voy a pedir un favor.
Dime.
Que o consigues que la marca esa de turrón nos patrocine algo o cambia el nombre a los seminarios, porque a ver cómo pongo yo ahora esto en el currículum.
No tienen ni idea, yo lo pongo y no saben ni lo que es.
Te va a costar, sí. No, el año que viene intentaremos que los del almendro nos paguen por lo menos los viajes y las cenas y estas cosas, o sea que...
Oye, Javi, las charlas las habéis grabado, ¿están disponibles?
Me alegro que me hagan esa pregunta, es lo que os iba a contar ahora, que no, en realidad lo iba a hilar porque, claro, no habéis podido ver las charlas de esta mañana, me imagino, estaréis profundamente dormidos, o bueno, Juan Carlos no sé si lo estaba o no, pero vamos, probablemente entonces la idea es que sí, se están grabando todas las charlas, se van a colgar en una web para vosotros y para los estudiantes y demás que no han podido seguirlas, y entonces os vamos a poner también en algún momento dado el link donde se cuelgan, ¿vale? O sea que sí, tendréis toda la información disponible, etcétera, etcétera, o sea que podréis seguir las charlas y enseñárselos a vuestros estudiantes de allí y demás.
Muy bien,
Muchas gracias.
Nada, gracias a vosotros, un placer teneros y nada, que espero veros lo más pronto posible, ¿vale?
¿Feliz solsticio de invierno?
Sí, señor, solsticio de invierno esta noche, vamos a celebrarlo ahora, como los vikingos. Que muchas gracias de nuevo, chicos, nos vemos en breve. Hasta luego.
Hasta luego.